So presentation topic is proximal junctional kyphosis in the setting of deformity. I'm Cameron Shirazi, one of the fellows here. So just an outline for the discussion today. We'll kind of go through definition, incidence, risk factors, implications, classification, prevention, and treatment. A lot of these things that we'll talk about when it comes to risk factors or topics in and of themselves that we've actually had discussions on earlier. So we'll try to kind of focus in on certain aspects here. So just overall definitions: adult spinal deformity, malalignment that occurs in the coronal, sagittal, or axial planes. It can be residual or de novo, or kind of the two big definitions. And then a lot of times in these situations, we treat these patients with multi-level fusion constructs. And when you do this, you set yourself up for risk of PJK and PJF. In a very broad sense, PJK is the formation. It's a form of adjacent segment disease and pathology that's seen after spinal fusion. And when you correct scoliosis or kyphosis, it essentially is a kyphotic change in the disc space above the fusion. In adults, fracture subluxations and long sweeping kyphosis above the fusion can occur. With more kind of technical definitions, when you're looking at the literature and trying to kind of see how this is studied and looked at, it is the proximal junctional sagittal angle from the UIV and the UVI plus 2 of at least 10 degrees and at least 10 degrees greater than the pre-op measurement. So that would be your definition for PJK. And then PJF, which in and of itself is a separate definition, is coincidence of PJK with fracture of the UIV or UIV plus 1, disruption of the osteoligamentous complex posteriorly, or failure of instrumentation at the UIV. And so those are specific definitions that help kind of guide the research. When this was being defined, different articles were looking at this, and this is a review article from Korea, published in 2016. And so although we had some clear definitions there, previous, the one that we talk about comes from Gladys. I don't know if I'm pronouncing that correctly. And so that is the greater than or equal to 10 degrees and at least 10 degrees greater than preoperative measurement. And this is that paper itself. And that was from WashU in 2005. They looked at early preoperative and final postoperative radiographs to look at the sagittal Cobb angle and SRS-24 outcomes. The proximal junction was defined as the caudal end plate of the UIV and the cephalad end plate of 2 vertebrae proximally. And so they had, when we're looking at incidence rates, which this next slide will have more of those broken down, you can see across the board, you'll see different values, and it depends on the definition applied in some of these papers, but you can see anywhere from 17% to 61.7%, but for the most part, it kind of funnels down into 20 to 40%. And Kim et al. Paper cited a 39% incidence rate at 7.8 year follow-up was the average, but I think the minimum was 5 years in any of those patients. And then in terms of timing, you'll see, when does this occur? When would you should be aware of this? It can be anywhere from this first paper notes 66% occurred within the first 3 months after surgery, and then Wang et al.'s paper 80% within 18 months after surgery. So kind of continuing with incidence and risk factors for PJK, a 2018 study looked at, it was a multi-center retrospective analysis, and their incidence, they had 314 patients that had incidence of 25%, and within this study, BMI greater than 25 as well as age greater than 50 both had statistically significant risk factors and had a positive correlation for the occurrence of PJK. Higher preoperative pelvic tilt had a positive correlation with PJK occurrence as well. And then revision in these settings, in their subset of patients that did have PJK, they had a 2.3% revision rate and that accounted for 15% of all total revisions within the revision patients in that study. This is a meta-analysis from 2016 in European Spine Journal. Once again, looking at incidence and risk factors for PJK. They looked at 14 studies within this, so it ended up being 2,215 patients. Their incidence was about 30% that they reached, and their risk factors that they identified are listed here. And so age at surgery greater than 55, fusion to S1. Here's a kyphotic angle, preoperative kyphotic angle from T5 to 12 greater than 40 degrees, and then an SVA difference of greater than 5 centimeters. And then we'll kind of get back to this later when we look at kind of different, more recent studies. But in this study, gender, combined anterior posterior surgery, use of pedicle screws at the top of the construct, hybrid instrumentation, and thoracoplasty were not associated with PJK in this study. Now, etiology, why does this occur? Why does this happen? You know, that's the million-dollar question. That's what everyone wants to avoid after these surgeries. And, you know, like I said, we touched on a lot of topics that relate to this, but some things are patient-related, some things are surgery-related, just, you know, what kind of surgery you're doing, what happens intraoperatively, and then some are radiographically, which kind of ends up being your balance and where you get these patients and what to expect when you put them in these positions. And so risk factors that can be identified via radiographic assessment, like we noted in those previous studies, high preoperative SVA or a high thoracic kyphosis greater than 40 degrees from T5 to T12. And then if you have a proximal junctional angle of greater than 5 degrees already at that level, you could be setting up for increased risk of PJK. And then patient-specific factors, like we noted, age greater than 55, BMI, osteoporosis, which last week we had that lecture on, and obviously that has obvious contribution to failure at the proximal extensor construct, and then smoking and other comorbidities, and so increasing age is in most papers directly increased with incidence of PJK and PJF. The BMI link is a little bit less clear, but it does seem obviously that increasing BMI would lead to this, and then the kind of osteoporosis like we spoke about. Surgical factors, so approach-related disruption of the posterior soft tissue, which is something that we talk about, ligamentous issues we're doing studies on, but disruption of that posterior tension band and intervertebral elements, including the facet capsules. Those in both cadaveric and biomechanical studies, which we'll have a few coming up, have shown risk for PJK. And then in newer studies, like I said, that one that we just talked about didn't mention or have a correlation to an anterior and posterior approach, but newer studies show that the combined anterior and posterior approach PJK is 3 times more likely to develop compared to posterior only approach. And then, but from the anterior approach, it's kind of unclear the actual mechanism of how that's happening. And then next thing is your construct rigidity. That patients requiring, or so that as we have increased stiffness secondary to pedicle screws, and now we began to extend fusions to the pelvis, you're increasing the rigidity of these constructs, and so these patients that you're taking down to the pelvis, they can sometimes be at higher risk. And then some of these are surgical decision-making questions, which we've had talks on before, but choosing your UIV, understanding how much of your SVA needs to be corrected, and then, and looking just at overall your global alignment and your alignment sagittally to see if we're doing the correct thing. And as we kind of go on to how to avoid this, we'll talk about that in a little more detail. But the tendency to restore everyone to SVA of 0 is, it may not be optimal for every single patient, same way their spine shape isn't optimal for every single patient. And so that's when certain things kind of, as we go on, will come into play. Clinical implications. So initially, the initial thoughts were this is just a radiographic finding. It doesn't really have, that much implication. But as time has gone on, we have seen this disease spectrum begin to occur. What can go from you see radiographic findings with no symptoms to, all the way to radiographic findings plus neurologic symptoms, et cetera, and other problems, failure of your instrumentation. So that's why the newer literature, when you look at it, it kind of speaks more broadly on this topic, that it's a spectrum of disease. And so as their pain increases, you can have worse clinical outcomes. And then ultimately, the goal is to avoid it going from this PJK to proximal junctional failure, because at that point, you're dealing with bigger issues and problems, and that's what you would like to avoid. And because that leads to things such as walking disturbances, neurologic defects, inability to maintain horizontal gaze, and ultimately can lead to reoperation. And then, as we talked about the difference between those two earlier in terms of the definitions. So, revision surgery subject patients to increased risk of preoperative complications, and they also have significant economic implications. They can nearly double the operative cost from a study from Hart in 2008. They had estimated cost of revision surgery at about $80,000, and that was from 2008. So further kind of discussion about the clinical implications. When you have PJK, it results in inferior SRS pain subscores in an adult deformity subset of patients. And so in this study, PJK incidence was about 40%, which is what we said is most papers kind of come to as the high end nowadays. And they had pain was significant in the SRS scores. In the ones that did have PJK, they had 29.4%, and then in the non-PJK, 0.9%. And so pretty straightforward is that the PJK results in worse clinical outcomes measured by SRS pain subscore. And then the incidence of upper back pain was highly predictive of PJK. In this study, had an odds ratio of about 12.5 with so that should be something you take into account when you're seeing these patients and they have pain proximally. Here's moving on to classification of this. This is proposed by Yaji et al., and it was revised after initial classification in 2012. So this is kind of a newer version. And so it's based on both etiology of the failure and the kyphosis angle. So they defined it as either being ligamentous failure, which is type 1, or disc, and then bone failure, type 2, and implant and bone interface failure, which is type 3. And then the grading goes from the proximal junctional kyphosis angle, so from 10 degrees to 19 degrees, and then they stratify them going up from there. And then spondylolisthesis, if that's involved as well. So they added that as well because they found within their study that the patients with the failures and neurologic abnormalities seemed to be the ones that fell into that spondylolisthesis category more often. The most common type was the 2N in this subset of patients. And then preoperative large SVA change and large amount of correction was a causative factor for spondylolisthesis above the UIV, was another kind of result or conclusion the study came to. Here's another study published by Hart et al. In 2014. This looked at 18 studies for risk factors associated with PJK, and they had the Hart ISSG PJF severity score, which encompasses many of these risk factors here, and it was a goal to provide classification system guide to help with management as well. And so the 6 components it involves are neurologic deficit, focal pain, instrumentation problems, changing kyphosis, posterior ligament complex integrity, fracture location, and level of the UIV, and that's all shown here in this table. And then these are then stratified and assigned a point value, and then you can calculate a final score from that. And so now the goal is to prevent PJK, and so we're going to look at different ways of preventing that. Like I said, a lot of these topics have been talked about before. We'll try to summarize these in the setting of PJK specifically. The first one we'll kind of touch base on is cement augmentation. And so it's thought to increase the pedicle screw pull-out strength and overall construct stiffness. But there's concern that when you do this, prophylactic vertebral velocity at the UIV, it could lead to further loading of the UIV +1, so the one above that. So you have to be selective when you're doing that. Sorry, I thought there was an additional slide between there. But this is looking at Hounsfield units. So when you're determining your UIV and how to avoid this, we've talked about this a lot of times before, but you kind of want to look at this and assess your patient's bone health before you start anything. That starts with your clinic, DEXA scans, checking that, and then also Hounsfield units help you decide where to do that UIV. These are just some various studies that I've added along here, but this is one from Japan in 2016, and it wanted to see if Forteo helped prevent PJK type 2, which was the vertebral fracture type PJK. And so in these patients, they had 2-year follow-up, and the type 2 PJK failure was significantly lower in the teriparatide group than in the control group. And so they thought that in their patients, prophylactic teriparatide treatment improved the bone mineral density and fine bone structure at the UIV +1 and reduced PJK type 2 incidence. So some of those things that we're doing in clinic and part of our workup for these patients, just showing where they work and if they work. This is another study from 2017 out of Miami that was in the Spine Journal. And so another one where they did prophylactic vertebral cement augmentation at the UIV and rostral adjacent vertebral segments at the time of deformity correction, and they felt it was preventative in the development of PJK as well as PJF. Now, there are also reports and studies looking at failure after cement augmentation. And so you get this from both ways, so it's hard to fully decipher, which one is the best, but that's kind of one subset of thoughts there. Another is, how do you your ending point, your UIV, are you ending it with pedicle screws, or are you ending it with hooks? How do you want to go about this? And so these are 2 different studies that look at various types of constructs. The Hassanzadeh study, they used hooks and pedicle screws at the UIV for patients who had already undergone more than 5 levels of instrumentation. And after 2 years, they had 2-year follow-up. They had 29.6% of the group with pedicle screws show symptoms of PJK, but no cases of PJK were observed in the patient group with hooks in their study. And then Kim et al. In the second study reported a lower prevalence of PJK in cases where they used hooks rather than only pedicle screws. But this, different subsets of patients here, but you can see the pedicle screw instrumentation, the hybrid constructs, and then the hook-only constructs. And then there was also a separate study in the AIS population from Spine in 2007 that looked at 3 types of posterior instrumentation constructs, and they demonstrated lower incidence of PJK with hook-only constructs as well. So now when you talk about prevention, different ways of going about that and how you need to assess the spine and what your goals are during surgery. And so this is a more recent paper from just this year, the shape of the fused spine associated with acute proximal junctional kyphosis in adult spinal deformity. And so this was a study that looking at measurements and how to find positive predictive value for PJK and how to look at that. And so they discovered that the 2 key vertebropelvic angles that most strongly correlate with PJK occurrence were L3PA and T11PA, and these are for fusion constructs that go up to T10. So this is not a kind of T4 to pelvis. In this study, they're looking at kind of those T10 to pelvis constructs. And what they note is that since your vertebropelvic angles are independent of patient position, L3PA, T11PA, and PR measurements, you can use them both preoperatively and intraoperatively. So that's kind of the goal and how to ensure optimal alignment. And the conclusion that they came to, they had about a 68% positive predictive value based on some of these measurements. And I think kind of the study is obviously more in depth, just trying to keep a broader view, but when you don't meet your goals of L3PA and T11PA in surgery, and so, but even then, it's a 68% positive predictive value, so it's still not as high as you'd think. So there's what this kind of comes to show once again is that there's a spectrum of causes that lead to PJK. It's not just one thing, and you have to take into account all of these things when you're looking at these patients. And then I think this one is a little bit out of whack, but this is kind of fine-tuning the predictive model for proximal junctional failure in surgically treated patients with adult spinal deformity. And so they looked at past studies trying to see what are the risk factors, what's the most important, and what should be taken into account. And in this present study, they, when you look at these, the PT, BMD, LIV, UIV, PSO, C7 SVA, BMI, they go down this range or this kind of spectrum of factors that are kind of play a role in predicting and noting if someone's going to lead to PJF. And they felt that when you have this combination of risk factors that fit their criteria, then their accuracy in being able to predict proximal junctional failure, not kyphosis, was 98% in their patient, whereas previous studies kind of going back to 2016, when you looked at kind of more limited factors and ranking them and what was the most important, their accuracy was about 86%. And so here is just another table that's looking at factors associated with development of and revision for proximal junctional kyphosis. And so this is their observed group here. This is their revised group here. And being able to see it's just another table kind of going through a lot of those same risk factors that we've talked about previously, and kind of showing a lot of the same findings that we saw. And then this is looking at the UIV and the femoral angle correlation to assess for proximal junctional kyphosis. And in this study, it's not, it just depending on where your UIV was, it's not looking at kind of T4PA, L1PA kind of specific factors. But what they noted from this study is that the greater magnitude of posterior translation of the UIV from the femoral head center from pre-op to post-op, the greater the likelihood of PJF. So the more posterior that is from the femoral head center after lower thoracic to pelvic surgical correction for ASD, the more patient risk for PJK. Patients with higher postoperative UIVFA and delta UIVFA, which is a way to look at overcorrection, were more likely to present with PJK at a minimum of 2 years. And so they kind of come to an optimal postoperative UIV FA cutoff of 11.5 degrees for prevention of PJK when you're trying to find like a set number from that study. And then things we've talked about before is, just your overall alignment when you're doing these long T4 or even higher constructs to pelvis, looking at the T4 PA and the L1 PA. We've talked about this study in Journal Club before, as well as Dr. Kelly kind of gave a talk going over this. And so, what they note is that the L1 PA accounts for both lordosis and magnitude and shape, and then the T4 PA had a fairly narrow distribution of values within 4 degrees, and then so often within 4 degrees of L1 PA in this study. And so if you're resetting the patients to this alignment, is this another way to avoid PJK? So that's another thought process that we're looking into. And then this is factors associated with the development of and revision of PJK, and so which we kind of touched on earlier. So I think these two were flipped, but thoracic kyphosis and PT are important indicators of overall rigidity and reference the ability of the spine to compensate for sagittal plane deformity. So PJF, if you have signs of PJF, they're obviously associated with increased rates of revision surgery, and so the being able to prevent it through sagittal plane correction and to avoid this sagittal plane decompensation may hold the key to reducing the need for revision surgery in these complex patients. And then this was just a snippet when I had from Dr. Kelly's talk earlier this year, talking about kind of the spectrum, and we have to balance these patients. If you have persistent compensatory mechanisms that you're trying to use to make up for this lack of balance, it can lead to, as you know, it's unfavorable biomechanical environment, and that leads to a huge subset of problems, including this PJF and PJK, and so another factor to look into. So when to intervene and when to treat asymptomatic versus symptomatic. You have to understand the implications of this before you jump into any type of surgery. But here's a 2013 study, multi-center. They wanted to see what patients, or what the characteristics that are associated with revision surgery. And in their patients, they had 57 patients, 27 of them underwent surgery within 6 months of their index procedure, and they wanted to look further into that. So factors associated with revision surgery were anything with traumatic etiology, combined anterior and posterior approach at index surgery as was kind of the highest, and then more extreme proximal junctional kyphosis angle. And so these are factors that we've talked about before, but they also, in this study, had a logistic regression analysis that looked at what influenced probability of revision surgery, and those were kind of those factors we talked there. But other factors include high SVA and female sex, and then the factors that kind of, those same factors play into who gets surgery. And so the factors that were expected to influence revision, but they didn't really kind of pan out in this study, included soft tissue versus bony mode of failure, age, levels fused, and upper thoracic versus thoracolumbar proximal junction, where it ended the construct. And then this is a study who will require revision surgery among neurologically intact patients, because obviously if someone has neurologic deficits with PJF or PJK, it'll push that can force your hand in of itself. But these are for neurologically intact patients, and so these were patients with PJF following surgery for adult spinal deformity, and they're followed for more than 2 years after they developed their PJF to determine the risk factors for revision. Bony failure and was the most significant risk factor based on their multivariate analysis. And then also looking at the proximal junctional angle was the second kind of major risk factor, although the bony failure was the biggest one that would push them towards surgery. And then in these patients, when they were looking at when they ran their statistics, they had about if you had 22 degrees, or if you had less than 20 degrees of PJA, less likely to have revision surgery. But those with bony failure and greater than 22 degrees, they felt should fall into the surgical category. And so then when you stratify these groups, the highest percentage fell in the bony failure plus that PJA of 22 degrees or greater, and then it was the bony failure plus PJA less than 22 degrees, and then if it was strictly ligamentous failure, not bony failure, it was about 12.5%. So conclusions here, it's a we saw the rates there. If you kind of look at the numbers and you go anywhere from 20 to 40%, that's still very high. So a very common complication after surgery. It's multifactorial. Like I said, we've had plenty of talks this year about various causes that could lead to this, that in and of themselves are giant topics that you could go into. And so you have to take all of those into account and have awareness of these, and to the best of your ability, optimize these patients. And so that starts before you get to surgery, and as well as your decision making during surgery, or, preoperative planning of where you're going to end your construct, how you want to balance these patients out, what's needed to do this, and then ultimately intraoperatively surgical skills, looking at how your dissection works, what you're protecting, and decisions like that. And then obviously postoperatively following these patients closely, and understanding that just because they have some of this PJK, it doesn't mean you jump right into surgery, but that there are certain things that would kind of push your hand towards surgery quicker than in other situations. So it's a big topic, and lots of debate about how to go about optimizing or treating these various things, and that's why we've had lots of talks on them. But it's important because this is, you don't want to see this after surgery, and you don't necessarily want to it leads to a lot of, bad effects ultimately and costly, like we saw from that one study. So that's what I got.
Awesome. Thanks, Cam. Yeah, big topic, and for sure, I think what you take away from all of this is how multifactorial it is, and how we're not quite sure what the what the actual mechanism is. But I think if you looked at like studies over time, we're I feel like we're getting a little better understanding of it, though. Like in other words, just even kind of in the whole classification article, I like that one. We use that a lot, and how you think about PJK, because the modes of failure are different, and then you have to individualize it every time. A lot of these papers are written off of multi-center databases, so surgeon skill and post-operative alignment outcomes they vary dramatically from center to center, and then you're making these generalizations out of a group of multi-center studies. So it's when you apply it to your own practice, it becomes a little bit more difficult. And as you gain more experience doing these cases, you'll kind of see your own trends, and be able to pick up on some of those nuances that are more particular to you. Like I think I tell you guys as well, like, always know how you miss on your pedicle screws. Like, and that's why it's probably, pretty valuable to get CT scans after surgery on a lot of them, or if you have an intraoperative spin, that you look at the spins, because you'll see if you're someone that misses low or high or medial or lateral, you'll see patterns, even in yourself. And you'll see that even your PJK failures have patterns for why they fail. Maybe you're someone that just chronically overcorrects people, and that may be the issue. So you have to dial back your correction, or the opposite, right? You leave people flat, so they're constantly compensating. So you'll have to dial in your own um, your own practice relative to what your patterns of failure are. So it's really important, if you're doing deformity surgery, to constantly be evaluating what you're doing. Um, you should do the same for your degenerative cases too, but deformity has a little higher risk with these incidences happening upwards of 1 in 3 patients. So just a few comments. Great job.
Hey, Greg, since I look at this as the natural history of what we're doing from a stabilization standpoint, we create all this rigidity in a system that's supposed to be relatively supple, right? Has motion, and we take it away. Have you noticed a change in your rates of this failure as you've gotten more nuance in how you do the surgery? Do you think you've been able to make a meaningful change, or have the rates stayed the same regardless of what you're doing? Because I know that we've looked at different techniques in tethering and soft tissue preservation and undercorrecting, and have you noticed a change?
Based on our data from our ligament study, yes, our numbers are down.
Okay,
So
you've been able to
I think
make
we have a 10% improvement, but which is not insignificant. But what I'll tell you is, like, the number of patients I reoperate on now for failure is lower.
Because they're not failing as catastrophically, it's more tolerable. What's going on?
I think, well, about 2 years ago, we shifted over to this L1PA, T4PA goal, and that's a goal that we can achieve in the operating room. And so, like, I feel like that probably is the most meaningful shift, because that means you have to shape the spine differently. You can't just throw in inner bodies. You got to be thoughtful about where you end up getting your correction. So I'm an undercorrector, though. Like, if you look at my failures, they're probably because I used to overdo it, and now I've swung my whole practice. Now I underdo it, but I underdo it for a reason, because if you look at the data, you have a little bit more margin on the undercorrection side than you have on the overcorrection side. So once you overcorrect, it is hard. It is hard. So overcorrecting leads to more problems faster.
So
even if you look at, like, Mike Kelly's paper on the L1PA, like when you have more margin on the undercorrected side. Like, you have to be within like 3 degrees on the overcorrected side, but within like 7 degrees or something like that on the undercorrected side.
So, and this is all adult degenerative stuff, right?
Yeah.
Yeah. Okay. So, because I think of this as our normal predilection as we age, not that I'm doing that, but as we age into kyphosis a little bit, that undercorrection margin makes more sense to me because we live in that different spot, our bodies do. So that makes more sense to me
Yeah, I
physiologically.
don't
Yeah.
know. I'm not sure I totally believe that. And life is a kyphosing event. I understand that. Like, I mean, as the discs
Yeah.
degenerate, but it doesn't mean that patients like being forward.
No. I'm not saying they like being
Yeah.
as far forward as the deformity pushes them, but when you correct them, you're creating some form of new harmony, new balance,
Yeah. Yeah.
in a better position that they're able to sustain more. I think I'm thinking about this in terms of it makes sense, and maybe why you're seeing less adjacent segment failure because you're not getting as much strain stress. I don't know the answer. I'm just thinking about this because these used to be catastrophically bad when they would occur sometimes with neurologic
Yeah.
deficits and everything else. Yeah.
So I think we're getting better, but we're definitely not there yet, you know.
Okay, thanks.
Awesome. Well, thanks, guys. 7:10. Great job, Cam.
Thanks, Cam. Yeah, great job. Thank you.